Welcome. Good evening, good morning, good afternoon to everyone. I'm very pleased to welcome you to, again, a webinar, some of the highlights of every month from ISSM. Today, the webinar is on pregnancy and sexuality. We are already more than 120 attendees. And again, I'm very happy as last time to say that we are represented in all continents, as we have one participant from the Antarctic, and we also have participants from the rest of the world. Can I have the next slide? For those of you who might not have joined our webinars before, I just want to remind you the vision and mission of the ISSM. My name is Annamaria Giraldi. I'm the president of the ISSM, and the vision of the society is that every human being has the right to a healthy and satisfying sexual life. And our mission is to be the most respected and trusted source of information, education, and professional development on human sexual health through the delivery of world-class publication, research finding, online and in-person opportunities for knowledge exchange worldwide. And the webinar is a part of this strategy. And I want to thank you, the Education Committee, for preparing the webinars and finding very interesting topics and experts that can talk to us. So the next slide. Another way of exchanging knowledge is our journals, and our journals is the Journal of Sexual Medicine, the Open Access Sexual Medicine Reviews, and our video journals. So please, if you're not a member, if you become a member, you will have access to our 4 journals. The next slide. So, as we know, the webinars were started when we could not meet in Japan, and I think they have proven that this is a very, very nice way to reach out to each other, to share knowledge, to share education. And again, I want to thank you, the Education Committee, for taking this great task and preparing these webinars. So the next slide. I just want to welcome our moderators and thank the moderators as well as our speakers for being here and share their knowledge with us. Our moderators today are Deirdre O'Malley. Deirdre is a clinical tutor in midwifery at the School of Nursing and Midwifery at the Trinity College in Dublin. She is a registered nurse, midwife, and clinical nurse teacher, and her research interest extends to many areas of maternity care and health research methods with specific topic expertises in the area of perinatal sexual health, and postpartum care. And Deirdre has the experience of both quantitative and qualitative research. So welcome and thank you to you, Deirdre. The other moderator is Woet Gianotten from the Netherlands. Woet is retired as an MD and psychotherapist, but he's still very active. Long time ago, when he started his medical career, he was working in obstetrics and gynecology, but very quickly, as he says, fell in love with sexology and had worked within the field. And many of you will know Woet from many teaching sessions in the ISSM and the ISSM. After he has retired as a senior lecturer in medical sexology, he has kept being active, especially in teaching sexology to healthcare professionals and writing articles and chapters. And he's actually the co-editor of a book on midwifery and sexuality. So welcome, Woet and Deirdre, and please take over. Thank you.
Okay, thank you very much. And then I'd like to introduce to you the first speaker. The first speaker is Sharon Parish. She is a professor of medicine in clinical psychiatry and professor of clinical medicine at the Weill Cornell Medical College in New York City. She's the director of medical services at the New York Presbyterian Hospital Behavioral Health Division, and her role includes oversight of the medical aspects of pregnancy, peripartum, and women's reproductive inpatient psychiatry services. She has a sexual medicine and menopause consultation practice for women and men at Weill Cornell Medicine. She's a member of the ISSM Board of Directors. She's the past president of ISSWISH, chair of the ISSWISH Clinical Practice Guideline Committee, and an associate editor for Sexual Medicine Reviews. So I'd love to give now the start to Sharon.
Thank you very much for this opportunity and this introduction. So I'm going to be speaking to you as the first lecturer about sex during pregnancy, what the average, I guess, clinician, provider, and person on this webinar should know. I'll be giving more of the research overview and some context, and then my co-speaker, my co-presenter will get into some real life situations and challenges. So next slide. Let's start with an overview of pregnancy and women's sexual health. As I think we all believe, sex is a healthy and normal part of pregnancy and postpartum. A woman's experience of her sexuality may evolve throughout the course of pregnancy, and education and counseling may influence and optimize sexual function during pregnancy. However, a lack of adequate information about sex during pregnancy and concerns about possible adverse obstetric outcomes are the most relevant factors contributing to the avoidance of sexual activity during pregnancy. And what's concerning is that only 31% of pregnant and 15% of postpartum women actually discuss sexuality with a healthcare provider. So this lack of information can be a real problem when women are facing questions about pregnancy and sexuality. Next slide. Let's talk about some general overview of the evolution of sexual function throughout pregnancy and what we know from some of the research. What you'll see from my citations throughout the presentation is that I tried to select as the key references publications from the Journal of Sexual Medicine and Sexual Medicine Reviews, and I brought in other papers as necessary. And given the limit of my time, the explanation about each study can't be exhaustive, but rather you'll find the information on the slide summative. So what we know in the first trimester is that sexual function is quite variable, depending on the awareness of the person, whether the person knows they're pregnant, the desirability of the pregnancy, feelings of fatigue and nausea, but generally it's relatively static or increased. In the second trimester, the data is mixed. Sexual activity may increase or decrease, and that depends on a number of factors. Whereas in the third trimester, women report that penetration may be less comfortable due to the physical changes of pregnancy, and report a decline in frequency of sexual activity as well as global function. They may report decreased or diminished orgasm and the potential for increased vulvovaginal and even deep pain. Postpartum, there's a decline reported in sexual function that may persist up to 3 to 6 months following delivery. There's a potential for increased dyspareunia due to birth trauma and factors such as breastfeeding, which may result in vaginal dryness and nipple sensitivity or hypersensitivity, as well as altered body image. I'll get into some more specifics about each of these trimester changes as we go along. Next slide. So I'm going to highlight one very specific study. This paper was published in 2017 in the Journal of Sexual Medicine, and it looked at the issue of sexual distress and sexual problems during pregnancy and the association with sexual and relationship satisfaction. This study used sexual functioning questionnaires that are standardized validated measures, including the FSFI and the female sexual distress scale, and also used validated instruments to assess sexual function and sexual and relationship satisfaction. So I circled some key data that I think it's important to note in this study of 230 women. Overall, about 36% reported a sexual problem. And of those women with sexual problems, 25% of them, of the total population, also reported coexisting distress. The most common sexual problems included desire and decrease in satisfaction and increase in pain. You'll see the numbers highlighted by arrows. And the desire was also the most distressing coexisting sexual problem. Next slide. Here I summarize some of the key findings and some other points. So sexual distress was common. And just to reemphasize, 25% of sexually active women experienced distress associated with sexual problems. An additional 14% experienced distress in the absence of sexual problems. And the rates of all domains of sexual problems, except for pain, was higher than non-pregnant women. Distressing feelings included guilt, frustration, worry, and embarrassment, even in the absence of explicit sexual problems. And women with concurrent sexual distress and problems reported lower sexual and relationship satisfaction compared with women with no problems. But of note, there were no differences in sexual and relationship satisfaction between women with concurrent problems and women with only sexual problems and only sexual distress. Next slide. What are some of the biological factors that impact sexual activity? Dyspareunia, both superficial and deep, can be associated with factors like pelvic vasocongestion, vaginal congestion with reduced lubrication, subluxation of the pubic symphysis and SI joints, a retroverted uterus, or the weight of the partner on the uterus during intercourse, especially during the 3rd trimester. Some common feelings or experiences may include fatigue and back pain. Women may feel the deep engagement of the fetal head. Vaginal infections can co-occur. Candida trick and bacterial vaginosis particularly can cause superficial dyspareunia. Other factors include hemorrhoids, the recurrence or occurrence of UTIs, stress incontinence, and vulvar varicose veins. Next slide. Women do adapt their sexual behavior and activity to the changes in pregnancy. Later 2nd and 3rd trimester coital position alterations that women often engage with include the woman on top or side by side or on all fours position, as well as re-entry. These changes are reported more commonly than missionary sex, actually. Alternatives to penetration are also described, including kissing, hugging, breast play, vibrators, the use of sex toys, massage, mutual masturbation, and oral sex. And women report that these behaviors do maintain sexual intimacy, especially if the communication is good between partners. And in fact, this may give a window into some of the ways to enhance education for women. Couples with better communication and greater degrees of intimacy engage in and negotiate a wider array of these sexual variations in research reports. Next slide. Another problem may be pudendal neuropathy. The pudendal nerve is the primary afferent nerve for the perineum, the vulva, and the clitoris. So pudendal nerve trauma can occur after vaginal delivery. So now we're getting into the issues of the vaginal delivery and postpartum. Compression of the nerve by the fetal head can result in acute nerve dysfunction and ischemic injury. Women can also have a stretch injury due to the prolonged 2nd stage of labor, operative delivery factors, and fetal birth weight. And these pudendal neuropathies and injuries and so forth can result in postpartum symptoms. Next slide. The delivery mode may have an influence on postpartum sexual function. So for example, in studies, a planned primary C-section prior to the onset of labor has the lowest rates of long-term sexual dysfunction, whereas normal spontaneous vaginal deliveries can result in genital and anal sphincter lacerations. Sometimes there's even an episiotomy that has to heal and causes issues. And women's report of postpartum dyspareunia, in some studies does relate or is associated with the degree of this type of perineal trauma. Operative deliveries that include forceps or vacuum deliveries are associated with the highest rates of short-term maternal and neonatal complications and longer-term sexual dysfunction reports. Next slide. So what about postpartum sexuality? Approximately 80 to 90% of women resume intercourse within 3 months. So, and that implies that this decline in sexual function kind of resolves on its own in most people. However, interestingly, 66% experience at least one sexual problem. This includes decreased libido, difficulty achieving orgasm, dyspareunia, and also dryness, which I'll talk about in a moment. These problems in general have been reported to usually resolve within the first postpartum year. To some extent, the resolution or the improvement of these sexual complaints is associated with premorbid sexual function, but that relationship is complex. The postpartum sexuality is also influenced by other factors, such as breastfeeding. There was some look in the literature about whether women actually reported an increase in sexual desire and eroticism when they were breastfeeding, but that really didn't bear out. And in general, the bigger problem is dyspareunia and vaginal dryness due to hyperprolactinemia and amenorrhea and sort of a trophic vaginitis that can occur due to breastfeeding. I mentioned the perineal trauma and the potential nerve injury. So women may also experience pelvic floor dysfunction, urinary and anal incontinence, which often resolves in a month or two, but sometimes that can set up a cycle of sexual dysfunction. But we don't have good studies on the role of pelvic floor physical therapy during pregnancy or postpartum as to whether this helps with the resolution. Some psychological factors, which I'm sure we'll hear more about in the next presentation, include adaptation to the balance and the role of the identity of a mother versus being a sexual being. And this is an area for discussion. The quality of the partner relationship and the woman's marital satisfaction or relationship satisfaction can play a role, as well as her body image. Of interest, primiparous women have higher reports of persistent sexual dysfunction into the first year than multiparous women. Next slide. I'd like to talk a little bit, because I work in the mental health area in my daily work, about pregnancy and postpartum depression. Sexual function, depression, and anxiety are interrelated during prenatal and postnatal periods. Depressive symptom scores during early and late pregnancy in one study were significant negative predictors of sexual function during pregnancy. So this idea of premorbid mood and anxiety plays a role. Women with comorbid anxiety and depressive disorders prior to pregnancy more often specified impairment of overall sexual satisfaction in a longitudinal prospective study that studied women over multiple points in time throughout the entire pregnancy. So again, this idea of premorbid assessment is an important point to teach healthcare providers, as well as early identification during the pregnancy process. As many of us know, postpartum depression is an important clinical problem, and it affects 10 to 15% of women. It impairs desire, as well as engagement with the partner and the baby. The most commonly used antidepressant medications, which often are teamed with what's safe and understood about safety and lactation, include SSRIs and SNRIs. And they, as we know, have an issue that results in impairment in sexual function, particularly libido and anorgasmia. So this may perpetuate or co-interact with the postpartum depression itself. Next slide. So my key take-home messages are that sexual problems are relatively common and increase later in pregnancy. Sexual problems concomitant with sexually related distress are associated with decreased sexual and relationship satisfaction. More treatment studies are needed on psychological, educational, psychosocial, or physiotherapeutic interventions for treatment of sexual dysfunction during pregnancy and postpartum. Educational programs for pregnant women can be used to clarify these misconceptions, myths, and doubts regarding sexual function and dysfunction. And the research points to the idea, and we know this from other areas, that integrated multidisciplinary approaches may be optimal. Thank you very much, and I look forward to answering your questions.
Okay, Sharon, thank you very much. That was a nice overview with a lot of information. Now, let me tell you a little bit about the rest of the program. There are no questions now. First, we will have the presentation by Dr. Padmini Prasad, and after that, you have full time for question and answers. So now I want to introduce Dr. Padmini Prasad, and let me look well and to say it properly. She is a consultant obstetrician and gynecologist and sexologist and marriage counselor, first qualified woman sexologist from Karnataka in India. She is the medical director of the Ramamami Nursing and Maternity Home in the Institute of Sexual Medicine in Bangalore. She is the president-elect of the Bangalore Society of Obstetrics and Gynecology, and she's a chairperson of the Sexual Medicine and STD Committee in India. So I give the floor to Dr. Padmini Prasad. Padmini, you can go on.
Thank you very much for that nice introduction. Good evening to you all. I take it as a privilege and an opportunity to be with you all in this great learning experience. I thank ISSM profusely for this. My topic today is pregnancy and sexuality, real life considerations. And as you could hear from the earlier speaker, sexual health and function are important determinants of quality of life. Sex is for procreation, recreation, and relation. When the woman conceives and welcomes her new bundle of joy, the whole family will be preparing to welcome the new member. The woman starts getting many advices regarding diet, sleep, travel, dress, etc. The only advice she is not getting is about the sexual relationship. Sex during pregnancy is a frequently misunderstood aspect of pregnancy. Obstetricians and healthcare providers, including nurses and midwives, should take more active role in counseling about intercourse during pregnancy and postpartum. So I am going to present some of the real life incidences or the case scenarios which I have encountered as a practicing obstetrician. How a lack of advice, lack of awareness can create serious problems for the pregnant woman. The important aspect is that these problems are preventable with a proper counseling of the woman and her husband. So let us go to this case scenario 1. Mrs. X, delivered 1 year back, came crying to the clinic. Reason? She detected extramarital affair of her husband with the maid servant. The reason? Abstinence throughout pregnancy and during post-delivery. If you consider various reasons here, number 1, the abstinence, and number 2, the lack of knowledge for the couple, the lack of advice and counseling by healthcare providers, doctors, midwives, and nurses, or the hospital staff. Cultural issues. In India, we have a lot of support systems, and parents take care of the pregnant woman. So throughout pregnancy and post-delivery, till the child is grown up. So around 5th to 7th month itself, the pregnant woman goes to her mother's place, and after delivery usually remains there 6 months to 1 year. So during this period, husband will be visiting occasionally, unable to have sexual relationship. So there will be long period of abstinence. So some weak moment and sexual urges and an opportunity there came as an extramarital affair. It was a love marriage. Trust is broken. Husband repented, but suspicion remains in the wife's mind. So can we go to the next slide? So there is a poll question. Do you regularly counsel the pregnant women? Very frequently, occasionally, rarely, very rarely, or never? So if this is over, we can go to the next case scenario. Next slide, please. Yes. You can see the most often it says only the occasionally the highest incidence of counseling to the pregnant lady. So next slide, second case scenario. Okay. In this case, one woman was repeatedly getting admitted to the hospital for the treatment of antepartum hemorrhage. She was frequently coming for bleeding per vagina. And all the tests, scanning, everything was normal. Everything ruled out whether there was placenta previa or any other reason for the bleeding. So one day I sat with her and took a detailed history. Then she started crying. So this revealed husband was forcing the wife for sexual intercourse every day, not bothering what happens to the wife. So a detailed sexual history in any bleeding per vagina or the watery discharge is very important. The relationship history. How is the couple's relationship? How is the husband's concern or love affection towards the wife? And from the healthcare providers, counseling of the couple. In case of such sexual abuse or the husband not cooperating with the wife, sometimes it may be necessary to admit her throughout the period of pregnancy till delivery, or sometimes the short stay homes are also available for the woman to stay. And there are also a lot of social economic issues and lack of awareness. These low social economic issues, illiteracy, male domination, alcoholic husband, and wife has no voice. So the understanding of the socio-cultural background of the husband and the couple is extremely important. Next slide, please. So another polling question. Do you think counseling is important? Very important, important, moderately important, of little importance, or unimportant? Yes, I'm so happy that very important, the maximum number have voted. So next slide, please. So this is another case, Mrs. B, a case of bad obstetric history with previous 2 abortions, having cervical stitch for cervical incompetence. She came with the ruptured membranes and liquor leakage at 30 weeks. Emergency cesarean section was done. Baby was kept in NICU. The history of intercourse previous night. The wife coolly asked me, Madam, is it because that we had intercourse during last night? So this is another thing, again, a lack of advice. The couple had not received any counseling regarding sexual relationship. All the advices after the cervical stitch, all advices were given about the rest, sleep, or when to come to the hospital if there is a problem. But nothing was told about sexual relationship. Couple was thinking because the stitch has been put, everything is okay, they can have the usual relationship. So we can counsel them. Sex is not just about intercourse. It can include other activities like hugging, kissing, oral sex, and other activities which can be of some importance to keep up the couple's relationship. Next slide, please. So this whole question, do your patients talk to you on sex regularly about sexual relationship? Is it always, very often, sometimes, rarely, or never? So sometimes, yes, it is the same all over the place. Next slide, please. So Mrs. D, 4 weeks post-cesarean section. She was admitted with fever, foul-smelling discharge per vagina. And the history revealed the reason, sexual intercourse. The husband had diabetes. He was having genital infection leading to puerperal sepsis for the woman. So here comes the importance of counseling regarding resuming intercourse after delivery and the proper advices, because usually it takes 6 weeks for the involution post-delivery. The raw area and wounds in the genital tract can invade these organisms and leading to sepsis. The source of infection was her husband's genital infection, and because of the diabetes, he was having recurrent balanoposthitis. He had not used even the condom also. So when to resume, and especially when the wounds are healed, then only they have to, after examining and seeing that all the wounds have healed, and what is the time duration of the involution after the delivery, all these things have to be given as a proper advice to the pregnant woman and the couple. Next slide, please. So post-delivery, when do you ask them to resume the sexual intercourse or the sexual relationship? Within 1 month, within 3 months, within 6 months, or within 1 year? Within 3 months, yes. So most, even the previous speaker, when she showed her slides, and most of the studies indicated that usually within 3 months, or it should be at least after 6 weeks post-delivery. Because even in our place, there are a lot of rituals at 6 weeks or 40 days, 42 days, they make it as a ritual that the healing has been complete and she can stay with the husband. So these are some cultural issues are also according to the scientific reasons. So here, another case scenario, she delivered 4 months back, came with pregnancy positive, 4 months after cesarean. The no counseling regarding sexual intercourse after delivery and especially the contraception. So after delivery, 2 advices are very important. Number 1, timing of resuming intercourse. Number 2 is contraception. It should be a routine. Advice can be given right from the time of antenatal period only. Specific advice about sexual relationship at the time of discharge post-delivery becomes extremely important. Nowadays, in our place, the insertion of copper T, what we call it as postpartum IUCD program, immediately after cesarean section or immediately after delivery, the copper T is being introduced so that can prevent some of the unwanted pregnancies. Next slide, please. So after all these things, with all these case scenarios, you could understand the woman's sexual function is a complex interplay of physical, emotional, and psychological factors between the couple or partners. Next slide. Every couple has plenty of questions regarding sexual relationship during pregnancy, but they don't because of the taboo attached to sex. Many couples do not consult the doctor. Many doctors do not think it is an issue to discuss. Next slide, please. Sex during pregnancy is a frequently misunderstood aspect of pregnancy. Unless physicians and the healthcare providers are familiar with the scientific data in the area, there is a tendency for providing misleading or incorrect information to the patients. Fear of abortion, infection, low energy are the reasons to forbid coitus during pregnancy. Next slide. Obstetricians and healthcare providers should take more active role in counseling about intercourse during pregnancy and postpartum. In many places, the midwives or the nurses who are close to the patients, they are giving sexual advisors. I'm so happy they are doing the midwifery and sexuality. Our moderator and the other lady who was doing a lot of work in the midwifery and sexuality, and they're writing the book also. I'm so happy about it. The physical, psychological, emotional, and relationship changes during pregnancy have a bearing on sexual relationship. Next slide. Studies show no relationship between sex during normal pregnancy, premature uterine contractions, or fetal distress and infection. So these various things, so previous lecture, you have heard about this, how it varies, all the different aspects of sexuality. Next slide, please. There are certain psychological usefulness and cervical maturation process which becomes favorable, and prevention of preeclamptic toxemia by sexual intercourse. These are some of the advantages of having a normal sexual relationship. A natural protection for the baby by cervical mucus plug, amniotic fluid, and strong uterine muscle will be there by nature. So sex will not harm the baby. Next slide. Advice should also be given about comfortable and safe sexual positions. So this has already been told to you. Next slide, please. So the man's concerns, when we talk about the sexual relationship for the couple and for the woman, the man's concerns should be looked into, and that is extremely important. The man may fear that sex can hurt the baby, worries about the wife's and unborn baby's health, apprehension about burden of parenthood, self-consciousness about making love in the presence of the unborn child. So doctors should discuss the fears and concerns with the dad-to-be and reassure and advise him. Next slide, please. With a little experimenting, each couple should work towards finding proper techniques that are suitable for them. Most important is communication and openness. They are the keys to maintaining or improving sexual satisfaction during pregnancy. Next slide, please. So coming to the take-home messages, sexual health and function are important determinants of quality of life. More focused research is needed regarding sexuality during pregnancy and childbirth. Most patients welcome the freedom to discuss this topic. Practical advice as a part of prenatal care should be a routine. Pregnancy is a very natural phase in a woman's life. We say that pregnancy and childbirth are not disease. Both pregnancy and sexuality are natural and normal phenomenon of a woman's life. Most pregnant women can engage in sexual activity throughout pregnancy in the absence of any complications. If at all, if there are the high risk pregnancy and complications during pregnancy, definitely the healthcare provider will be giving advice to avoid sexual intercourse. Thank you very much for the patient hearing and for the opportunity.
Thank you very much, Padmini, for a very interesting presentation. Both presentations were very interesting indeed. So I'm going to open up some of the questions that have come through on the Q&A, and there's quite a few questions there, and some have probably already been answered, but I'm going to make a start here, and one of the questions that I'm going to direct towards Sharon, and the question is, what impact of prolactin on postpartum sexuality, if you wouldn't mind, Sharon?
So the research has been a little sketchy, separating the direct impact of the hormonal influence on libido. And we know that we have some evidence that hyperprolactinemia has been associated with low sexual desire in women. Separating that out as compared to the multifaceted or multidimensional impact of breastfeeding on libido and sexual desire. But I think it's understood, and it's hard to tease that out because there are other factors that change, particularly sexual desire in breastfeeding women. You know, whether it is just the focus on the baby, the new baby, the idea that the breasts and the sexuality, the breasts are now for babies and not for sexuality. There's a lot, we could talk about some of the psychological responses to breastfeeding, as well as dyspareunia and discomfort and dryness leading to low desire. That's an area that I found a lack of specificity in the research. But the assumption is made that the elevation in prolactin that occurs because of breastfeeding, has a direct effect on sex drive and sexual desires. It does in non-postpartum women with hyperprolactinemia. I don't know if the other panelists have any comments about that.
Yeah, I'd like to come in on that a little bit. I suppose I can't answer the question directly about prolactin, but my own research would indicate that there's a complexity for women who are breastfeeding their babies, the view of the breast previously for sexual arousal, and now the view of the breast solely and exclusively for feeding the baby. And many women that I would have spoken to and interviewed as part of that research would have had conflicting feelings about that. There was also the association with body image and the physical leaking of milk, and women talked about squirting milk. Women talked about the changing size of their breasts and shape of breasts. But then women were also quite clever. They talked about, they would plan when they might engage in sort of sexual activity around feeds and things like that. So I do think it's an interesting one, and certainly your estrogen levels, they have a significant impact on, as you already said, Sharon, the vaginal lubrication, which of course has an impact on sensation and feeling and discomfort. So I think it's a complex one, isn't it? And there's room for more research in that area.
Yeah, I just want to also, so I just want to comment in response to that. Sorry, is just that it's very important when taking a postpartum sexual history to sort out what's actually came first. Are you having pain and then you have the sexual response, or, did you just independently lose interest in sex? Sorry, go ahead. I didn't mean to interrupt you.
I want to add just a little bit on that area of breast and sexuality. Some 30 years ago, I did research in Rotterdam, asking women the consequences of different things in their life, in their reproductive life. And also I asked about orgasm when they were giving breastfeeding and that kind of sensations. And 8% of the women who had been lactating told that they had had an orgasm just by breastfeeding the baby. And there you can see the very strong connection between oxytocin and orgasm. That's a very strong connection together. So it's good to be added here. Okay, the next, Deirdre, you have a next question?
Sure, yes. So I'm going to go ahead with this question, and this could be to either of the presenters, if you know the answer here. So this question is quite specific about the impact of the placental unit on androgen production, especially long term. As OBGYNs, we hear constantly that our patients feel less interested in sex after pregnancy. Has anyone looked at the difference in androgen levels in women after pregnancy, perhaps compared to those who have not been pregnant, or those who have not been in the intended caregivers or parents of offspring? I don't know, which of you would like to maybe?
Naturally, post-delivery, the hormone, there will be a lot of hormone changes and decrease in the estrogen and increased level of prolactin are one of the reasons for little decreased desire. But the androgen, though, even if the level is decreased, I don't think we can use androgen during pregnancy or postpartum, because even for a normal low desire, the lot of studies regarding the actual dose of the androgen or the testosterone is not available yet. But so the postpartum use of testosterone or the androgen is definitely ruled out, because it can affect the other aspects of the pregnancy, lactation, and postpartum period. So one thing in the postpartum, what I do is teach them the Kegels exercises, so that they can recover the muscle weakness or the Kegels, the pelvic floor muscles, pubococcygeus muscle strengthening. That will also help them when they later resume their intercourse. And the other thing is, they should see that all the wounds are healed well and there is no infection. And in the beginning stages, when they are resuming intercourse, they can use lubricants. I also prescribe them lubricants. I teach them Kegels exercises. So when they actually start the exercises and then resume intercourse, they're quite happy. And if there is any dyspareunia, or if there are any episiotomy, suturing, stitches, or painful scars in the area, they should immediately come and report. So these are some of the advices I give in the postpartum period also. Thank you.
I just want to make a comment. I think directly, there's no research on that I came across or I'm aware of on the impact of placental function on testosterone and androgen levels in women. One interesting thing is that this is an age group where generally testosterone levels have not started to decline. And there's been questions about the role of, suppressed ovarian function and transient decreases in testosterone in pregnant and postpartum women and the role of that in libido. But I think, as you mentioned, the rationale for testosterone replacement postpartum, is lacking. It's not an indication, because generally these aren't considered postmenopausal women. And if they're breastfeeding, you have to look at the issue of, the fetus and so forth. I have no idea if transdermal testosterone, it's never been studied as to whether it goes in the breast milk, because it's just contraindicated. So, really in a methodological, well done study. So those are my comments.
Deirdre, you have the next question.
I do indeed have the next question, yes. So this is a second part of question, because some of these I think have been answered during the presentation, so I'm not going to kind of rehash them. But one question, initially directed to you, Sharon. This person has read somewhere that sex can be done during all steps of pregnancy. To my opinion, I think this is wrong because of the presence of prostaglandin E2 in the sperm, which contract the uterine muscle and consequently speed up the delivery process. Is this person right?
Well, the research hasn't supported the idea that sex during pregnancy, even later in pregnancy, accelerates labor or delivery. So I understand the biochemical or physiologic concerns. The guidance is really that the decision to have sex is a collaboration between her and her physician. There are individualized factors that may influence the recommendations around sex or specific sexual behaviors, penetrative, non-penetrative, et cetera. But in general, there's no recommendation to avoid sex later in pregnancy. I don't know if the other panelists have a comment.
I'd like to add just a little bit. One of the troubles is that regularly one part of sexuality is not allowed in complicated pregnancies. And then if the healthcare professional doesn't mention what is allowed and only mentions what is not allowed, then the couple gets in distress. So it's always important to tell, don't do this, but you're allowed to do that and that and that and that. It's all possible. That's a very important message in clinical message.
I'd like to just add to that as well, and I think it's a bit of a wider discussion. A lot of the evidence that I'm familiar with that talks about postpartum sexual health and sexual issues during pregnancy, it's very focused on penetrative vaginal intercourse. And it's a very narrow view of intimacy, sexual satisfaction, and all of those things. So it just kind of stands to the point that you're making there, Woet. I think that, you know, it's talking about other things for sexual satisfaction.
I tend to say nobody should start a pregnancy if the couple is not able to have sex without intercourse. That should be a starting point before you get pregnant. And there is a lot, that's what we find as well in oncosexology, in the problems after somebody has got cancer. Then they mention that very lovely in Australia, they say renegotiating intimacy. And then in that renegotiating, it's very important that they can do without having penetration. And the same happens in the last months of pregnancy and in the first months after delivery, that they can have sex without penetration, and you can do a lot with it. And what we tried to promote is what we call intimate masturbation, where the woman, usually the woman who has lower desire because she is very pregnant or she just delivered, that they together can cuddle till she says, that was nice, thank you very much. And then the man can masturbate himself in the arms of his wife. And that's a way which, and I think nowadays with the COVID, we accept masturbation much more as a normal part of sexuality. Maybe that could be a good change for the future as well.
So I'd like to just jump in and make a comment about COVID, because I figured somebody might throw in a question. And there's a real paucity of research on the impact of how COVID is affecting pre-antenatal, pregnant, and postnatal sexuality. But I think we need to understand this better. I do know we have some research here on looking at the impact of COVID on young mothers, new mothers, and it's very, very hard on them because the isolation is very high. There's no play groups and so forth. And I'm guessing we'll learn that has an impact on the woman's well-being and happiness and engagement and sexuality as well. But we need to learn more about this as we come in depth.
During this COVID pandemic, we have seen many cases of infertility cases who are coming for treatment. Most of them have conceived because they are able to have sexual relationship and increased intimacy and all that. They have conceived. That is one thing. And during this COVID, once they conceive, then also a lot of questions in their mind of whether to go to the hospital, whether to have online consultation, and whether the pregnancy will be normal. So all these botherations again, that also came in. So during, it was very difficult for them to come to the doctor, and especially if they are COVID positive, then again the isolation, a pregnant mother in the isolation, and also post-delivery. So otherwise, so many, around 10 women used to surround her and give support to her, and to stay alone when she became COVID positive was really very difficult situation for her.
Okay, there is another question. Women who have got IVF, then quite a lot of patients and partners are afraid to lose the baby. What advice do you give them regarding sexuality?
Yeah, this IVF naturally with so much of difficulty, they have conceived and high risk pregnancy, they're using a lot of hormones and other medicine. So we can always tell them, because if it is a high risk pregnancy, definitely we ask them to have non-penetrative sexual relationship, no penetrative sex, and other activities they can to maintain the intimacy, a good communication and other hugging, kissing, and being close to the woman and being close to each other with a psychological satisfaction. All these things can be advised. Definitely most of these IVF pregnancies, they are high risk pregnancies, and after a long period of struggle, they have conceived. And naturally, even if you advise them to go in for intercourse, usually they don't. So they say, no, we are scared. We don't want to have that. So that much, I think, determination will be there after a long period of struggle when they are becoming parents. That's what I have seen.
Okay. Deirdre, you have a next question for you.
I do. Yes, I have. So there's a question here, if I can. Okay, so a question, because we talked a little bit, Padmini, we talked a little bit earlier about when women resume sexual activity after birth, and a question here asks about any peer-reviewed literature about when to resume sexual, IC after pregnancy. I'm going to assume intercourse.
Yeah. So most of these studies, whatever studies they have done, the safe period is after 6 weeks, because even scientifically, medically, that it takes 6 weeks for the complete resolution or completely the whole genital tract to come back to the normalcy. So that is how they advise after 6 weeks. But most of them, usually they start by third month. That's what I have seen, at least till third month. If there is no advice, I have also seen patients coming 2 years after delivery and then asking whether we can start having intercourse. So after 1 year, 2 years, they come and ask whether we can have intercourse. Because sometimes even the parents restrict them not to have intercourse. So that itself is one way of preventing unwanted pregnancy. So that also a cultural thing is there in our place. So they're really confused. With, even if we say that after 3 months you can start resuming, no, doctor, in our house they say we should not have intercourse till you complete the breastfeeding. So these things are there. We have to look into these cultural viewpoints, and also, but medically, whatever advice we can give, I think third month is the safe period, but after 6 weeks with protection, they can resume intercourse. I think Dr. Sharon can also tell, she was also presenting some of these studies.
I mean, I think the data, I was showing the data about women's reports and studies looking at function and dysfunction. But those decisions aren't based on, that women make generally are not based on good, detailed and specific advice. I think it varies across the world and across cultures, and the interaction between messaging from, guides and family members and so forth compared with clinical settings varies. But, that is the message medically is 6 weeks. But again, it's usually 3 months or so when people generally report that they resume. And it may have to do with when they feel well. I think you brought to light in your case some of the challenges, which is, how do you counsel on contraception and, and if there's persistent dysfunction like pelvic floor dysfunction and pain and dyspareunia, and many women breastfeed for longer than 3 months, where does the counseling come in on not only many women resume sex, but aren't comfortable or aren't enjoying it? So I think there's that whole interaction as well, in terms of learning what problems are emerging and how to ask them about it and how to address treatment. And I think I mentioned it, but the studies on treatment are really lacking in all areas. We need to understand better how to approach it in all phases of the pregnancy process.
Okay, one question here was on the penis size. Does that affect the uterus during pregnancy? I don't know if it's a male or a female question.
One thing is that we advise in whatever position they have sexual intercourse, avoid deep thrusting and avoid pressure on the abdomen at any stage. So we always, and that's why the suitable position where there is no deep penetration. So in that sense, the size of the penis does not matter. So in such conditions.
Okay. Any to add, Sharon? Not. Okay.
That is known. I think, again, this is a practical answer, probably more than a scientific answer, which is, the woman needs to be comfortable and all the factors in where she is in the pregnancy, uterine size, et cetera, all need to be looked at. I think there's an under recognition of the role of the pelvic floor muscles in being able to be comfortable during sexual penetration and allow, the penile entry or object entry. We need to learn more about how to use pelvic floor therapists, physiotherapists. when women have report complaints.
Yeah, okay. Deirdre, another question.
I have a nice question here. Should sexual history be part of every antenatal visit?
100%.
Go.
100%.
Anybody who knows me knows that it should be part of everything. It should be part of
Every conversation.
every conversation. We should always take a sexual history.
Yeah, but I think,
Please go ahead. Yeah.
I think in this case, yes, because we are dealing so much with a woman who has been laying naked in a room where people walking in and out. So if she has got a sexual abuse history, then we have to know that. Yeah. I think that is so important. So I don't think there are many outside the medical setting, so many situations where you have to be sure about sexual history, but here you have to know. When somebody starts IVF or somebody starts the process to get a delivery, you have to know if she has got experience of abuse, yes or no. And if it was by a woman or by a man, you have to know that as well, to be sure if the healthcare professional should be a male team or a female team.
I think this, all joking aside, I think we need to differentiate the history about sexuality and sexual trauma from the history about current function and the enabling the capacity to report complaints and ask questions, and then the engagement in a dialogue about addressing concerns or problems as they arise. These are all different tasks, and understanding where they fit in to this whole context is a really important area that we need to learn more about. Because again, you're talking specifically about a detail about the woman's past, but there are other domains and they each need attention.
Yeah.
I'd like just to contribute there. Coming from a midwifery perspective, I would like to see some sexual health history taking at a minimum at the first booking visit. And then I think we can start preparing women for potential changes to their sexual health during the antenatal visits or during parenthood education, moving away from dysfunction, but just normal changes, what you might expect, and to recognize when things actually, this is not a normal change, this is problematic, and start giving people signposts of where they may be able to go if they perceive things to be abnormal and if they perceive things to be causing them distress within their relationship and their intimate relationship. So at a minimum, I would like to see something happen in the booking visit, and then part of your antenatal care at different points. Sometimes you talk about birth planning, sometimes you talk about caring for your baby, and sometimes maybe you talk about sex after birth.
Okay, let me see. If somebody, I think that's a question for Sharon. Which interventions are preferred for postpartum depressions instead of using antidepressants?
Well, I think that's a very, great area for discussion. I think the preference for treatment in terms of treating postpartum depression really depends on a number of factors. I think if the woman it demonstrates to us that it has to do with cognitions, for example, ruminations about the baby's well-being or anxiety about being able to care for the baby, approaches like CBT and mindfulness, and that's part of the picture of the impairment in her sexuality, can be very useful. If she has a biologic depression and we know that she has premorbid biologic risk factors, then the best choice is going to be a medication in many cases. If it has another, mental disorder spectrum, often postpartum depression is attributable to the emergence potentially of bipolar disorder, for example, or there's more concerning features, then you have to use medication. But the issue I think I raised, and again, this is a wonderful topic, is we need more research on differentiating subgroups and really looking at the impact of sexual impairment by medications on maintaining and improving the sexual function of postpartum women and how that balance gets met in someone with postpartum depression. We really don't know how to balance that out. And we don't even know if women with postpartum depression are more likely to have treatment emergent sexual dysfunction when they receive antidepressants. It was something I raised as more of a question than where we really have good answers. But I think all of the usual interventions for depression and postpartum depression need to be thought about carefully as regards to sexuality.
Deirdre?
Yes, I've lost my question, but I can give you the gist about it. And it was, and I suppose maybe it's an interest of my own. The comment or the question is about, we're very much talking about men and women, opposite sex relationships. And I wonder if either of the presenters or Woet has any comment about the lack of visibility of women in same-sex relationships and their sexual health during pregnancy and postpartum.
We need more studies on that, and this more and as we start seeing more and more of these patients, then probably we understand them, what are their problems, and then the counseling also should be according to what exactly we get the history. But history should be a part of this, whatever it is, whatever relationship it may be. But history of sexual history during antenatal visit is a must.
Okay. I've got a question here and I have no idea about the answer. I would like to know your approach considerations when managing a patient with postpartum anorgasmia.
Yes.
Go ahead.
Yes. So earlier you were telling the orgasm, the woman can have an orgasm even by the nipple stimulation, even by the breastfeeding. That is the real thing many women will tell. So sometimes they even feel awkward when they get the orgasm by breastfeeding or with the nipple stimulation. But orgasm still can happen, and oxytocin release also will be there. If it is a specific problem, that time it is more of intimacy and satisfaction. So there is no need for orgasm to happen also if there is a good relationship between the couple. So I don't think there is specific treatment for anorgasmia. I don't think many people will complain. So Dr. Sharon can.
So I think it's the answer is that there's no research on specifically how to be more effective in managing anorgasmia in postpartum women as compared to anyone. But I think I would approach it with kind of better understanding about the etiology. So for example, not all women are breastfeeding, right? I don't even know if it's really true that based on the evidence that breastfeeding women are less likely to have anorgasmia, but certainly the mechanism of oxytocin and nipple stimulation might be erotic to some women and result in orgasm, but not to everyone. It really depends how sensitive the nipples are and how they feel about it and so forth. I think what I would do is go back to what we were talking about, which is take a history. So is this primary or secondary anorgasmia? Is there another sexual dysfunction that's coming from earlier in the cycle? Are they having low desire for a variety of reasons we mentioned? Do they have dryness? Do they have pain? Or is it the way she's interacting with her partner? Is she not, before she's self-stimulated, now she's not? Is she still having pelvic floor muscle dysfunction and pain? And looking at all of these factors and understanding why anorgasmia is either presenting or developing. And I think, then the traditional treatments include treating other sexual dysfunctions, looking at lubrication, improving stimulation, including self-stimulation or partner stimulation, and introducing, things such as vibrators, et cetera. I don't think there's any trials on medications. And I mentioned if it's an antidepressant-induced sexual dysfunction, you have to weigh the risks and benefits of potentially, for example, treatment emergent anorgasmia with an antidepressant. I don't know, Woet, if you have other thoughts, but I don't think there's anything more specific to this situation other than understanding the postpartum challenges.
I have no idea what to do with this specific question, no orgasm after getting a baby, but I should be interested in what is the role of if it is a male partner, what is the role of the male partner in this case? Because up till now, I didn't hear very much about the male partners, and he's rather relevant as well in the process, not only making the baby, but also afterwards. I'd love to hear some more from both of you of the male partners.
Yes, actually, it is the husband who comes and complains, but my wife is not enjoying as she was earlier. So I think you'll have to give her some treatment, less desire, and she is not enjoying sexual. The woman does not complain, but the husband so many times comes and complains that the wife is not enjoying.
I think you're bringing up the idea that we need to expand the role of seeing the couple together. And I think the woman often needs help in communicating with her partner about other ways to bring her to orgasm and to stimulate her when she can't have penetrative intercourse or it's painful. And the variations on sexual behavior, learning more about stimulation. And I think meeting with the patient or partner together can often be helpful, because I think men are looking for education, and we you can't put the burden of this on the woman necessarily. It's very hard for her, especially if she hasn't had to. Younger women haven't actually, maybe they haven't learned or haven't had to ask for what they need or want when things change with pregnancy. Yep. So, we know with the menopause literature that men are interested in seeking education and understanding the changes in their partner's bodies, and they would welcome it. There's just no place for them to learn. And I think we need to think the same way about the role of a male in sexuality and pregnancy.
Okay. Deirdre, other questions?
Yes, I have an interesting question here. How would you prepare a woman during pregnancy with vaginismus for delivery and possible internal vaginal examinations? It's very clinically based.
So vaginismus and for the natural conception, sometimes it can happen even without penetration. The pregnancy can happen just by the deposition of semen around the genitalia. I have seen so many ladies with vaginismus just conceiving, but they never had any intercourse earlier. So all these things, even during postpartum, if that persists, as a part of treatment of vaginismus, we have to do that desensitization procedure. Otherwise, this has to, in the interest of the couple relationship, we have to treat vaginismus, counsel them properly. At least later, after delivery, at least they can have proper intercourse. For a normal delivery, then definitely a severe case of vaginismus, very difficult. At that time, during pregnancy, if some relaxation exercises, Kegels exercises, all these things, if that can be taught, and she is comfortable for pelvic examination, and if she is capable of having normal delivery, then that can be done. Otherwise, it is we have to use some during labor analgesia and other things, and then deliver her.
Sharon,
I mentioned this multiple times, but I think involving, if you work with a pelvic floor physical therapist, this is a great place to consider more robust involvement. Yeah, that would be something I would also suggest.
Yeah, I'd like to add a little bit that in case a woman with vaginism comes to get pregnant or comes pregnant, we always have to be sure, does she really want to have intercourse afterwards? Because part of them just simply don't want. They are very happy with the life they have. And the babies can come out anyhow. They are not disturbed by vaginism. They know how to get out. So it's up to us to do it in the proper way and not to handle in the wrong way the woman. And that's not always easy if you are, let's say, the traditional midwife of traditional gynecologist approach. Then you want to put your fingers inside, and that is in the vaginism patient not always wise. But I'd love to hear that from the midwife and the gynecologist, their comments.
Yes, I think it's about having that very woman-centered approach, isn't it? And enabling women to labor without, as you say, putting your fingers in to determine if somebody's dilating. There are other ways to assess progress without doing vaginal examinations. But unfortunately, most of the obstetric units and maternity services I'm familiar with, women aren't in labor until you've confirmed it. And that's usually with the vaginal examination. It's horrendously distressing for women with vaginismus. So sometimes I have seen you, and this is personal experience rather than evidence, I've seen women using Entonox during an examination, but it still feels very invasive. to put a woman through a traumatic experience like that. Ideally, I think we should, as you say, the baby will come, labor will progress, and assessing fetal well-being in the normal ways and looking for the other signs of progress in labor. There's no reason why we can't rely on those skills that we have.
Okay. Any comment of you? Then we go to the next question. Yeah, maybe a little bit a continuation of this question. What to do with a woman who has been sexually abused, and it is clear that she has got a history of sexual abuse. How to deal with the delivery? I think that's for Padmini.
See, if once you have a history that she was sexually abused, right from the antenatal period, you should keep on counseling and preparing her mind for the delivery. Or if she is against that pregnancy, or if she doesn't want to go through pregnancy, childbirth, then that becomes a different issue. So once she is already pregnant and she would like to have the baby, and throughout pregnancy, a proper counseling will go a long way in having a normal delivery or whatever, depending on the obstetric indication. So I don't think there is any specific thing or any other thing, unless she is psychologically scarred and there is chances for going into postpartum depression. So such a history and with a depression, that is one thing which you have to look into after the delivery. If she doesn't like to feed the child, doesn't want to look after the child, and so these are some of the issues we have to look into. A careful observation and careful counseling should be there. That Sharon may be having experience with.
No, the counseling is, awareness and counseling is critical.
Deirdre, you probably will have seen a lot of such patients.
I wouldn't say a lot. Again, it's about whether some women don't disclose a history of sexual abuse. And again, it's always about that sort of woman-centered approach. What can we do for you to make this experience not a traumatic experience? So if you have continuity of carers, so if this woman could be cared for by the same midwife who she trusts throughout her pregnancy and in labour. And some of this is quite idealistic, certainly in the environment that I'm familiar with, but that would certainly be of comfort. Reducing the amount of persons that are in the room during birth. And again, avoiding those invasive examinations, internal vaginal examinations, and taking the woman's lead on what she needs and what she needs in order for the process not to be a traumatic one for her. So for me, it always kind of comes down to asking the woman what can be done for her, and ensuring that she has the support person that she wants, and privacy maintained. Sometimes in maternity units you see doors swinging open, people coming in for nonsense things like gloves. When there's gloves in storerooms, you shouldn't be coming into a room that has a laboring woman in it. So it's those things I think are important.
So there is the style of how we care.
Yeah, the style of the care and how we communicate.
I'm sorry to interrupt, but I think we need to wrap up. So maybe Woet and Deirdre, do you want to add some final comments?
That was such a fast hour and 15 minutes, wasn't it?
Yeah.
I just want to say thank you to the presenters and Woet and the ISSM for inviting me to moderate. It's been a really enjoyable, and I've learned from this afternoon. Thank you very much. And Woet, I'm looking forward to working with you over the next year.
Okay, maybe I just give one more question. What is a good book on pregnancy and sexuality? That is one of the questions. So I have to answer. The book is coming. It will. I guess it will take another year before it's there. It will be a book from Springer, and we are with a group of authors, many from midwifery and sexuality, and we are preparing that. It must be a very good book. So wait another 1 year, and then you will see that.
So thank you.
True.
So you have to look for Woet's name to see the book coming up. I think I'll have just one slide. First of all, you can see the sun start shining in Denmark. I hope it's shining wherever you are in the world, maybe even on the Antarctic. I want to thank Woet and Deirdre for moderating. I want to thank Padmini and Sharon for excellent talks. And I want to thank the organizers and the Education Committee again for organizing this. We have been more than 200 people, so thank you for everyone who have participated. The webinar will be made available on the ISSM University, so please go to our website and you can see the webinar again. And if some of the questions have not been answered, usually we will send them to the presenters, and hopefully there will be a response to you if we have your email. And then I just want to remind you of our next webinar, which will be on a completely different topic. It will be child sexual abuse in men, trauma and sexuality. So I hope I'll see you all April 29th, and I wish you a good evening, morning, afternoon, wherever you are, and thank you everyone.
Okay,